Okay, for this laboratory interpretation clinical pearl, I want to cover what hypothyroidism does to physiological systems and how it can express itself on different laboratory tests. And by hypothyroidism, I mean clearly when a patient is in a physiological state where there's not enough thyroid hormones to impact their body, their TSH would be elevated, they're in actual endocrine thyroid hormone deficiency, high TSH. Now T3 and T4 can fluctuate off and on, that's not as stable, but if the TSH is high, they're hypothyroid. Now, sometimes it'll be important too because you might see laboratory markers like really high cholesterol or abnormal homocysteine, and you may not know that it's related to some impact from hypothyroidism. Other times you'll have patients that come in that have had laboratory work with like a basic chemistry panel, and they may have high lipids or abnormal transaminases, and you think that maybe there's something there, but it could actually be a red flag too that they have hypothyroidism. So I've made this chart for you, and this is a chart that explains the influence of hypothyroidism on laboratory patterns, and I'm going to go through each one of these one by one. But one of the things that happens when people have thyroid hormone deficiency, and actually the most common thing you'll see in a hypothyroid state, is there is impaired degradation of lipids. So when someone's in a hypothyroid state, remember that their metabolic rate is just not efficient, right? Thyroid hormones impact the metabolic rate, and metabolizing out lipids and clearing out lipids requires thyroid hormones. So a lot of times you'll see really abnormally high total cholesterol levels or LDL levels or triglycerides when someone's in a hypothyroid state. And for many people that are on thyroid medication, it's actually one of the biggest clues that they need to get their TSH checked again because the lipid panels are off. Now, people that don't understand this will just go, oh, we got to treat the lipids and we got to do something for the lipids. But in most instances, when you see someone who has high TSH, it would not be unexpected for you to also see high lipid markers. And it would be best for them to get their thyroid replacement managed so their TSH is down and then see what happens to the lipid panel. And a majority of the time, if someone's in a true hypothyroid state where their TSH levels are actually elevated, you'll see this hyperlipidemia pattern. And this hyperlipidemia pattern will normalize in many, many cases when they're on replacement and their TSH levels go down, or if they need to increase their thyroid replacement. So one of the most common things you'll see is hyperlipidemia in a hypothyroid state, and it's corrected when their thyroid hormones are managed properly to bring their TSH levels down. So that's very important to know. You don't want to have 5 other medications and supplements and other things to manage this when the actual true issue is the hypothyroidism that's causing impaired degradation of lipids. Another common thing is when someone's in a hypothyroid state where TSH is high, is their transaminase levels are elevated as well. And SGOT, SGPT, GTP, they're improperly referred to as liver enzymes. They are not liver enzymes, they're transaminases. The reason I say that is SGOT, SGPT, and GTP are found in virtually every major tissue of the body. They're found in skeletal muscle, they're found in the heart, they're found in the liver, they're found in the kidneys, they're found in different cells in the body, red blood cells, for example. So when their levels are elevated, all you know is that some of this enzyme that's in cells is now in bloodstream. So typically they indicate some tissue breaking down. It just happens to be that the most common tissue that typically breaks down is the liver, so they got this negative association with, or incorrect association with being liver enzymes. So SGOT, SGPT, GTP are transaminases, and they're enzymes within cells that transport amino acids across cell membranes. Now, when people, and to say it differently, or to explain what's happening here in hypothyroidism, is we have these enzymes in our tissues that transport amino acids across the cell membrane because proteins can't go through passive diffusion. So these special transaminase enzymes transport these amino acids across the cell membranes, and eventually as some cells break off and die and there's some leakage of these transaminases into the serum, into the bloodstream, we'll have some level of these in the bloodstream. So no one has 0 levels of SGOT, SGPT, and GGTP. If you look at any lab range, there's a normal reference range, and there's some amount of these transaminases that's always found in the blood. But when people have breakdown of their tissue, these levels are going to be higher because more cellular breakdown, more of these transaminases are in tissue than just normal leakage of them in the bloodstream. Now, in hypothyroidism, what happens is there is no increased breakdown of tissue. It's just the body under hypothyroid states has impaired ability to clear them out. So the SGOT, SGPT, GGTP levels can be elevated at times in a hypothyroid state. And once again, if the hypothyroidism is managed, meaning by their TSH is normal, it comes back to normal, and they're not in a true hypothyroid deficiency state, where the pituitary is pushing out TSH to make that thyroid work because it's in a deficiency state, these transaminases will also come back to normal. Now, sometimes you see cholesterol levels up and not the transaminases. Sometimes you'll see the transaminases up, not the cholesterol. Sometimes they'll both be up. It all depends on how that person's metabolic rate is at different tissues, at different functions, at different times. When the snapshot's taken, hypothyroidism, what shows up. Now, another mechanism that can also take place in hypothyroidism is elevated homocysteine. And the process of methylation, which transfers methyl groups from homocysteine down to cysteine, down to cystine, is requiring metabolic rate that thyroid hormones are involved with. So when someone has actual true hypothyroidism, high TSH, their methylation pathways are inefficient, so they can't methylate, they can't transfer methyl groups. And actually in these states, you're going to have a very hard time using B12 and folate to get much effect, because they may have the precursors that just don't have the metabolic energy that they need for thyroid hormones to make this process happen. So if you ever see like homocysteines that are not responding, and you don't have a TSH to compare with, you should always run a TSH panel. And also, if you ever see lipid panels that are up all of a sudden for no reason, or transaminases that are up for no reason, if you don't have the TSH measurement, make sure you get that TSH measurement. So another key thing is that hypothyroidism is going to impair methylation pathways. And that can be reflected with high homocysteine on lab test, or higher homocysteine than usual for them on lab test. Okay, now let's get into some other things that show up. And there's two possibilities here that are hypochlorhydria and leaky gut syndrome. And I got to make something very, very clear with this part of it. On this chart, when you see total protein and total globulins, high or low, it could be either or, one or the other, but if any of these are involved. In this section, we're referring to the functional ranges. And we have functional ranges which are tight ranges, like the globulin level 2.4 to 2.8 and total protein is 6.9 to 7.4. These are called functional ranges. These are like healthy population ranges. And this sheet, this functional laboratory evaluation sheet, is in the resource library of the Clinical Mastership Program platform. So if you go to your resource library, you'll see a functional laboratory evaluation sheet, so you can see it. So when you look at functional ranges of globulin 2.4 to 2.8 or total protein 6.8 7.4, and you see slight elevations at high or low, that may occur at times with hypochlorhydria. We're not able to digest their proteins very well, or sometimes with intestinal permeability. And you should always suspect that those things may be occurring if you see these functional abnormalities of total protein and total globulin. Hypochlorhydria is going to also have symptoms that are associated with like burning, bloating. They eat proteins. They may have intolerance to it. They may have a hard time digesting proteins like eggs and meats and things like that are really rich in protein. Leaky gut syndrome is just going to be the classical developing food sensitivities, chronic pain, chronic inflammation. They may have both together. There's another resource tool in your resource library called the Metabolic Assessment Form. There's an actual section of symptoms associated with hypochlorhydria. There's actually a section of symptoms associated with intestinal permeability, leaky gut. So you always want to give a clue of what's happening with these. Now these are, in this whole sheet, these are the only ones that are really most concerned with the functional ranges. The rest of the markers on this panel are referring to the conventional laboratory range, not this tighter, healthy functional range. Now you're going to see some people in hypothyroid states develop anemias, and there's two different types of, there's different types of anemias you can develop. Let's talk about the megablastic anemias first. So megablastic meaning the red blood cells are enlarged. So if you look over here, we have both B12 anemia and pernicious anemia that are involved. And the main difference between B12 anemia and pernicious anemia is that B12 anemia is due to a deficiency of B12 in the diet, or B12 absorption, and pernicious anemia specifically due to antibodies to intrinsic factor blocking antibodies that is an autoimmune disorder impacting B12 absorption. So the key thing is, if you have a person who's hypothyroid, they may not have enough metabolic rate to optimize their B12 absorption, or there's about 5%, some studies show about 5% of people that have Hashimoto's, and similar with Graves' disease, that also have antibodies not only to their TPO and thyroid globulin associated with Hashimoto's, but they also have antibodies to intrinsic factor. So it's not uncommon for someone who has hypothyroidism to develop a megablastic anemia. And remember, anemia is defined by reduced amounts of red blood cells, hematocrit and hemoglobin. Hematocrit and hemoglobin are part of red blood cells, so when red blood cells are low, these are also low. So in the red blood cells, hematocrit, HCT, or hemoglobin, HEB are low. That tells us we have anemia. And then we look at the volume size and the concentration of hemoglobin to tell us if it's like a normal size or a small size or large size. So these are all increased, so these are all large. So this is megablastic. So these high MCV, MCH, MCSE make it megablastic. The RBC, hematocrit, hemoglobin being low, make it anemia. So this is megablastic anemia. And the only difference between the B12 anemia and the pernicious anemia is that intrinsic factor blocking antibodies are positive. So what does this mean to you clinically? So if you have a person who's hypothyroid, or in most hypothyroids are Hashimoto's, but if you ever have a patient who's hypothyroid Hashimoto's, and if you see megablastic anemia, see if their TSH is high, and if their TSH is high, and they're only having an issue with just absorbing B12, because you need fuel, you need metabolic rate at your intestinal cells to absorb nutrients. And if their TSH is high, sometimes when their TSH is normalized, their B12 anemia normalizes unrelated to taking extra B12 and folate. However, you have to realize that they probably have a subtle deficiency. A test that can clearly tell you if you have B12 deficiency would be methylmalonic acid. Folic acid deficiencies are not very common. Your intestinal microbiome makes folate. Unless someone has been on severe antibiotics, they may not make folate. Don't confuse that with like the MTH4 polymorphisms, where people can't process folate pathways. But to have not enough intestinal folate made to prevent anemia is to have severe enough. I should say differently. To have your microbiome so disrupted and your body's own ability to make folate dysfunctional is very uncommon. Even though genetic uniquenesses with methylation, like having a MTHFR folate polymorphism, are very common. About 1/4 of the population, they're not the same thing. So if you actually see a megablastic anemia, it's typically B12, not really folate. Okay. Now you can check methylmalonic acid. That's the most sensitive marker, even if they don't have intrinsic factor, because just some people that have subtle B12 deficiencies will really show up when they're in a hypothyroid state. Sometimes normalizing their TSH will optimize their B12 absorption, so their megablastic anemia may improve altogether. Now, other times, they just have co-autoimmunity, comorbidity with not only Hashimoto's, but also with pernicious anemia. So pernicious anemia is just megablastic anemia, but autoimmunity against intrinsic factor. Intrinsic factor is the transport protein that carries B12 across the intestinal cells. This is his own autoimmunity. With intrinsic factor blocking antibodies, managing TSH and thyroid hormones won't typically fix this. They may need B12 shots, or even sublingual B12s can sometimes work to get B12 in. But oral B12 has a harder time being absorbed since these antibodies are there. Now, some people can normalize pernicious anemia with oral B12 supplements, because even though their intrinsic factor, the carrier protein of B12, is being attacked, by the immune system, it's not 100%. So if they take, X amount of B12 and folate, some of that percentage will be absorbed even with antibodies. Other people, there's no way they'll get their B12 and folate absorbed if their autoimmune response control factor is very aggressive. They'll have to do B12 injections, or maybe they can try sublingual to see if it works. And the only way you will know is by retesting. There's no indication from symptoms alone. You'll just have to retest and see if it worked. If nothing is working with sublingual or oral supplements, the only other option is calm down their autoimmunity and use B12 shots. Since they can't absorb it to their gut, they're going to have to get in their bloodstream. So this is another. So the megablastic anemia pattern is also common to see with people that have hypothyroidism. Okay. Now, the other type of anemia is a normocytic normochromic anemia. And this is also common to see with people that have hypothyroidism. And what defines normocytic normochromic anemia is that they're anemic, their hemoglobin, hematocrit, and RBC are all depressed, they're all low, but the volume of their red blood cells are normal. So normal mean corpuscular volume, normal mean corpuscular hemoglobin concentrations and hemoglobin. And these are all normal, so normal size. So this is normocytic normochromic anemia. And normocytic normochromic anemia, you should always remember, is not associated with the nutrient deficiency. It's actually associated with inflammation. And sometimes when people are in a hypothyroid state, they're in a normocytic normochromic anemia pattern because they're inflamed. And many times just being back into a normal state and a TSH is normalized from thyroid hormones, you may see this change. Other times the inflammation from their usually underlying Hashimoto's autoimmune response is so great, this won't go down until their autoimmune inflammatory response goes down. Now, something that's very closely related to that is looking at these acute phase reactants. C-reactive protein, ferritin, transferrin. Most commonly, you'll see C-reactive protein or ferritin on a lab test. These are acute phase reactants. These go up in inflammation. Transferrin goes down in inflammation. And it's not uncommon to see many Hashimoto's, hypothyroid people that, for example, have a recent thyroid attack. Thyroid cells get destroyed, and now they're in a hypothyroid state. And the amount of thyroid hormones they were taking before are not enough because they've had more of the thyroid gland destroyed by the recent autoimmunity. And during that autoimmune response, their inflammatory reaction goes up. So these acute phase reactants like C-reactive protein and ferritin also go up. And it's not uncommon to see these associated with the autoimmune flare-up or something that's driving their inflammatory system when people have hypothyroidism Hashimoto's. Sometimes just thyroid hormones have an anti-inflammatory effect, especially the first 10 days, 2 weeks people take them. Other times it just gives you a clue that there is an inflammatory process, most likely the autoimmunity not being managed. So sometimes you'll see these acute phase reactants elevated. At the same time, you'll see the normocytic normochromic anemia. The inflammatory response is the main cause of normocytic normochromic anemia. So inflammation impacts the development of red blood cells, but it doesn't change their size. So you'll typically see normocytic normochromic anemia and acute phase reactants in Hashimoto's people and have severe flare-up. Now, again, each of these are going to have their own unique expressions, and there's not a rule, but any of these mechanisms are possible. Now, the last form of anemia you may see in hypothyroidism is microcytic microchromic anemia associated with iron deficiency anemia. So with iron deficiency anemia, we have low hemoglobin, hematocrit, and RBC anemia, but the volume is smaller, which means the volume of the cell is small and there's less red blood cell hemoglobin, hematocrit levels. The mean corpuscular hemoglobin and the mean corpuscular hemoglobin concentration, they're also low. So this is a microcytic, small size, and less hemoglobin, hypochromic, microcytic hypochromic anemia, iron deficiency. And in the actual hypothyroid state, there could be impaired iron absorption just due to the decreased metabolic activity. So a lot of times the TSH levels, when they're normalized, the person can absorb iron much more efficiently, and just fixing the thyroid fix their iron absorption issues and They had plenty of iron in their system, they just weren't absorbing it. The process of absorbing iron requires a lot of energy. And the other key difference here is ferritin. It's an acute phase reactant, but sometimes when people have iron deficiency, their iron reserves, ferritin serves as iron reserves and as an acute phase reactant. So in iron deficiency states, the ferritin levels are low, the iron storages are low, actual iron level in the blood could be low, total iron binding capacity being probably the best marker to identify iron deficiency. This is high. When someone's in iron deficiency state, there is a demand to make more binding sites for iron, so the TIBC is elevated. So you can get a microcytic hyperchromic anemia pattern with anemia, and sometimes just fixing the TSH may be very useful. So these are all the different patterns you should be aware of when someone has hypothyroidism. Okay. Now, when someone's in hypothyroid state and their TSH is high, you may see none of these. You may see a couple of these. You may see one of them. It's just so different from one person to the next. But you need to know that these patterns exist, so you can be very careful to not think that the lipid panel needs to be treated or misinterpret SGO-TSPT, GTP as thinking that some tissue's breaking down or if the liver's unhealthy. And you should know that these strong relationships between different types of anemias and an actual hypothyroid state. Okay, I hope this chart was helpful for you, and thank you for your attention.